Nice to be here. I appreciate the opportunity. I admitted to some hesitation. I am not a psychiatrist, and I stay totally in the hospital most of the time, other than having a home hospice program. So I was a little intimidated by the talk, but then started reflecting on the fact that I have had the ability to interact with a lot of family members throughout this, and have had my own personal journey with my children as we live through the quarantine as well. So I guess we'll piggyback off of that. I have nothing to disclose. And so our learning objectives is to see what's out there in the research about what we understand the psychological and physical wellness of families is during COVID-19, and then thinking about the unique stressors and perceptions that complex healthcare families have during the pandemic. And then also trying to say, okay, great, you have a palliative care doc here. Is there things from our world that translates into this situation in your world as pediatricians that can help you? So I did a big old search, and the reality is there's not a lot out there yet, and there's even less on children with medical complexity. So what I have here is a couple articles that we have about families in general in the midst of COVID. And so this first study, and all these studies happened at pretty much during the quarantine period and lockdown period. So most of this data is going to come from about March to June is the very latest we have. And so this study enacted very quickly after the shutdown. So data was collected between February and April of 2020, and it happened in a large US city. They don't disclose where. And what they really wanted to look at is they smartly started having daily surveys sent to families who had hourly wage jobs. And what they were looking at are 4 areas of distress that could be happening to families, and they're listed here. So parental job loss, income loss, caregiver burden, and illness. And they actually checked in with families about these 4 mechanisms of burden each day when they were sent it on their cell phone to complete. And they did all sorts of fancy statistics for dropouts and things like that. And what they were trying to see was how these mechanisms could link to the well-being of adults and children during the pandemic. And so what they found from this, and I'm moving sort of fast because we have a lot of articles to get through. You guys got the slides, and if you want to know more about the study, I promise I have some comment sections in there as well, and we have a link for you. So if we could move to the next slide, we'll sort of get to the bulk of it, which is what they found was parents' negative mood or affect, or irritability, their sense of agitation. That was definitely more frequent as a result of COVID-19 and the quarantine. They had a marker of sleep patterns, thinking that would be an indirect marker of wellness. They did not see a change there. But what they did see that wasn't necessarily statistically significant at the time, but saw an increased trend, was a presence of the children having more uncooperative behavior, and the parents perceiving that their child were more sad and more worried on a daily basis. And most markedly, these trends showed up within days of the lockdown, which I suspect surprised none of you in the work that you do. And what we then also found through this study is that the hardships, the things we talked about, like job loss, illness, etc., these absolutely tracked with and worsened psychological well-being, both for the parent and the child. And most importantly, these were cumulative. So the more hardships you experience, the more parents said they saw a negative impact to their own or their child's psychological wellness. Okay. And when I say wellness, just so we're working with the same definition, what we really are focusing on in this study and the next study we're going to talk about is not just physical wellness, right? So when we talk about wellness as a whole person, we're really talking about this dynamic process that happens within a human that thinks about the physical, the mental, and the social well-being of a person, okay? So it's more than just the absence or presence of disease. So the next study that I found was a survey. And this survey then looked at a much larger breadth of people, or number, I should say. So this included over 2,000 surveys being sent out to parents who had children in the home under 18. And they did a reasonable job getting about 50% or a little more than 50% of people to respond. So a nice response rate. It happened here in the United States, and it happened between March and June of 2020. And what they did here is they asked, as you can see here, about multiple things impacting their wellness, right? So they looked at health status, insurance, food security, did they have to use public food assistance? And then they also wanted to see where was the consistency or lack thereof of being able to provide, have childcare. And also, finally, they were looking at healthcare services, if they had access to them or not. And what they found through this study was that food insecurity increased. So people, as you probably could see, had less likelihood of having consistent food access from day to day. That jumped from about 32% to 36%. And then the ability to have regular childcare provisions dropped by 25%, which was pretty marked. Okay. And then they also started noting that these, again, like the last study, such stressors tracked with the psychological and physical wellness as perceived by the parents for themselves and their children, which we can elucidate on the next slide. So what they specifically found that in terms of psychological wellness, mood worsened in about 20% of parents. And then parents reported, there was no self-report by children in this study, but parents reported that their children denoted a worsening of behavioral health in 14%. Similarly, we saw declines in physical wellness as defined by the parents. The parents themselves thought that their health declined by 17.7%, and then they saw almost a 4% drop in their children's physical wellness. Note that this study was a one-time survey. It was retrospective by the time they were asked. So they were asked to think in June, about March till up in June. And obviously they didn't include children. So take those results with that light. So as we move on to COVID-19 and specifically looking at how this is impacting children with medical complexity, I will let you know that I couldn't find a lot. And so I will beg your permission to try and extrapolate several studies and then highlight the ones that we do know. So when we use the phrase, medical complexity, I did a lit search based on sort of the idea of this is a chronic condition lasting over 12 months. It impacts one or more organs significantly, requiring typically more than one subspecialist. So probably self-limited myself in my ability to find articles. Having said that, in general, a study out of Chicago, again, during the time of the quarantine, and then looking at it afterwards, found that in general, pediatricians' offices saw a decline in visits during the quarantine. You're, I'm sure, not surprised by that, with the ability that it increased to higher numbers post the actual shutdown. So well child visits fell during that time by about 50%, but then bounced up to about 90% of 2019 comparatives within 8 weeks of the quarantine being done, or at least the shutdown, I should say. But what they also saw during this is a change in the reason for a sick child visit. So while well child visits fell, they saw an increase in symptoms, a lot of them related to COVID-19 concerns, cough, fever, rhinitis. But what they also saw was an increase in the amount of concerns and calls for mental health concerns, very specifically a rise in anxiety amongst their children. So we are getting a signal out there that wellness of families and parents perceiving that in their children did rise during the shutdown. In a study in Italy, they also noted that very specifically, families of children with complex care needs had a decrease in emergency department utilization by about 60 to 65%. The reason that the parents took their children to the emergency department didn't change, but the overall percent of families willing to go to the emergency department fell markedly. And so I don't know if you can recollect yourself, if you had similar happening with your families. I will tell you, and we'll talk about it more as a palliative care doc, I absolutely anecdotally saw this, and enough that I was talking to my colleagues around the country, and we all actually felt a marked decrease in the number of our children in palliative care in the home setting willing to come in during that period. So again, because I didn't have a lot of studies that I could find specific to what I kind of perceive as my classic definition, I looked at other children who have medical complexity and tried to figure out, is there any research that we could extrapolate from? So there was this very nice study that came out about children with cancer and the parental perceptions of the impact of COVID-19 on their child's care. And this was a qualitative study. So they had, I apologize, I got to find my notes. I can do this for you. I'm trying to remember how many families it was. I'm so very sorry. I apparently just didn't. Oh, here we go. About 171 families participated. And in this, through a qualitative measure, they allowed parents through some open-ended and also some closed questions to sort of process out loud their experience with COVID-19 and as it impacted their children. And then in good qualitative research, they did analytics and they came up with these themes that emerged out of these conversations. And that's what they reported out and what is here. And so what they found, and I broke this up to sort of the schematics and the logistics, and then the next slide is going to talk about the mental wellness. So logistically speaking, the parents had a marked increase in concerns. One of them was access to care. Very specifically, will there be a bed for my child with cancer in April of 2020 because of COVID, or will my child risk not being able to get care as they once were able to because of an allocation issue? And then there was very much a sense amongst families that the COVID-19 and the need to be safe and PPE and all those issues was more important to hospital systems than the actual cancer. And they didn't elaborate a lot on that, but it was a marked finding. They also then sort of shifted to other aspects outside of healthcare and said there was a lack of priority status in retail stores. So while people who might have been 75 and older could go to the grocery store at 5 in the morning, they didn't feel as parents of kids with oncologic processes that they could. And so they felt like their families were at increased risk. But then they concomitantly said it's impractical to go and try to tell my children to socially distance, that is like impossible to ask a child to do. And then there was a real fear what would happen to the child with cancer if his or her parent became sick with COVID. How would that impact the child's ability to get good care? And heaven forbid, if I died as a parent, what was going to happen to my child? So real logistical fears by families. Similarly, there was a lot of emotional strain that happened and was found in this study. And so on this next slide, you'll see that from an emotional standpoint, the isolation that the quarantine caused really was triggering for families with cancer. As you probably could imagine, some of these families have spent 2 months, 6 months in the hospital while their child was getting back-to-back chemotherapeutics and then enduring the results of the anemia, the thrombocytopenia, et cetera. And so, for a lot of these families who might have been on the back end of chemotherapy, they really were having almost acute traumatic stress responses to then having to go back down on lockdown and what that meant for them. They also noted there was a loss of social support if they chose to bring their child in or had to bring their child in for therapy. So once they used to be able to have the siblings come and their spouses could come or their partners, grandparents might have been able to come by, and now there was maybe a 1 or at most 2 visitor rule going on in hospitals. So an already complex situation was made a lot worse by the requirements of not allowing a lot of visitors in hospitals. And then there was also a general sense that I think this and many of the other themes I just talked about could really extrapolate to children with medical complexity and their families. Parents denoted a real strong sense of loss of control. They already had loss of control for having a child with a cancer diagnosis, and then you throw in a pandemic and answers not being able to be answered, and what next, and now the schools are down, et cetera. So a very marked sense of increased loss of control. So this last study, it really, unfortunately, has nothing to do with COVID, because unfortunately, I could not find a single study on how the siblings were experiencing COVID-19, the siblings specifically of children with complex medical needs. I also couldn't find a study on the patients themselves. So what I decided to do was take this study, which was pre-COVID, but really, again, through that qualitative sort of process, ask siblings to illustrate and teach us what did it mean to be a sibling of a child with medical complexity. And what they found through, again, these themes is that really, really important to these kids, as we know is appropriate developmentally, are groups, right? Group identification. Then these children identified a couple groups that were of particular importance to them. And one was the group called family. And so the core unit was very important to these children. They derived a sense of pride from being the siblings of a child with medical complexity, but they also highlighted that there is a very strong sense of responsibility, maybe put upon themselves, but also they identified that their family, their parents in particular, identified that they had a real responsibility to the family unit to care for and to protect their sibling. So one could extrapolate from this that you add the added stress of COVID, and how does that sibling protect their sibling with complex medical needs? Could any of us felt or still feel like we can protect our loved ones during COVID? So you could imagine that that was really accentuated during this period for these siblings. And then almost in direct contrast and almost maybe in conflict is the other group that was really found to be important to these kids was their friend group. And they very clearly called out that one of the reasons a friend group was important, other than the developmental needs that all children should have a friend group, was this was their time off from responsibilities. So you could imagine during COVID, and now they're maybe not even allowed to go to school, or they're bubbling so aggressively that they can't see any of their friends live. They're also losing that time off from their responsibilities that the family unit sort of asks of them. So one could imagine that their wellness could really start being affected by this. Two other findings that this study highlighted was the children of found and stated that there's a lot of stress and isolation, even pre-COVID, when they're not able to be around their friend group. And they were talking a lot about, I'm different. It's harder to be part of friend groups. I don't have the spontaneity that another child may have because mom can't just jump in a car and drive me to the baseball game, etc. And that they really felt that when they weren't able to identify a friend group or be able to have easy access to their friend group. And then finally, they also highlighted, and they did it very kindly, but they highlighted that, there was a financial strain and a logistical strain that can happen to families who have children with medical complexity. And that, again, it was harder to go, maybe splurge and go to the movies, both financially and logistically getting them there, or other things that maybe, again, would have allowed them to have time away from responsibilities and be with their friend group. So I think we can take all this and try to wrap it in our minds about then what happens when COVID, and we try to pull in those past studies we talked about where financial stressors and illness impacted the parental perceptions of physical and psychological wellness. And then also thinking about that study from the cancer families about then parents are feeling all these other new stressors or triggers. And you could imagine there's a lot on parents' plates and children's plates facing the pandemic when you also already have a child with complex medical needs. So what to do about all this? I think part of it is just really trying to say, okay, if we could extrapolate and take pearls from those studies we just reviewed, how do they inform me when I know that I'm getting a call or an ask by a family member, right? Because I think that insight, that background by which we have a lens and then hear a request really can ensure that we're hearing the questions correctly, and that we have the right framework as we engage in the conversation. And then I think the other thing we can do is to really say, okay, I'm going to engage in this communication, but it sounds like a very nuanced and complex communication. And then thinking about your communication toolbox, as we like to say in palliative care, and how can I use that to facilitate these conversations? And so just to always put a plug in to make sure that everyone's thinking about my lovely specialty in the right way, because we suffer from the worst public relations nightmare ever. Is that as a palliative care doc, this is how I define palliative care and why I think all of our toolboxes are important for every pediatrician to have. And so we are a medical subspecialty, and we care for patients, but also their families who face life-threatening and not necessarily life-ending conditions. And we focus on the medical aspect, trying to mitigate symptoms of pain and other burdensome symptoms, either because of the illness or because of the treatments we're using to try and care for the illness. but we also try to attend specifically to the spiritual, emotional, and psychosocial needs of both the child, the family, and the siblings. And most importantly, this can happen in concurrent with curative care. So hospice is a certain type of palliative care, and that typically means life-limiting end-of-life care. But palliative care is a very broad field that we like it when all you docs fix kids. And so I'm here today just to talk about our communication toolboxes. And so when we have, about 2 papers out right now, more are coming. But when we think about COVID-19 and how it's intersected with pediatric palliative care, we were able to note through one study that conversations about quality of life and COVID-19 and how the two are intersecting are happening. And this study looked at, it was an analytic conversation, listening in on conversations between physicians and parents. And what they noted was, it was quality of life was being brought up. It was being brought up about 50% of the time by physicians, and then the other 50% of the time it was spontaneously being brought up by the parents. So, the takeaway from that is this is on parents' minds, and we need to either be listening for it, and if we don't actually hear the parent broaching it, then maybe we as physicians should be broaching it, because it's certainly on people's minds. And what's specifically on their minds are how COVID-19 and all the risks of COVID-19, specifically coming to an emergency department, right? We saw that it dropped by 65% coming into the hospital. Those risks are being weighed against potential benefits of coming into the hospital for a family. And so do they risk the ED waiting room? Do they risk your waiting room in your pediatrician's office because they feel it's important to be seen in person and not through telehealth? And so, that was being discussed in this study. I will again share anecdotally, as I referenced earlier in this talk, that I absolutely saw a trend in about April and May where my children who were home on home-based palliative care, were lucky enough at Columbus to have our own hospice and palliative care home-based programs. We care for about 60 kids in their home. We felt very much that the rate of do not resuscitate orders was rising. I think parents were really having mortality on their mind and felt a need to talk about it. We also felt very much that parents were uncharacteristically waiting a lot longer to bring their child to the hospital, and the children were therefore showing up in the hospital much sicker than what would typically have happened with our families of complex medical needs, which was, as you all know, that parents having that spidey sense that I can't put my finger on it. I know you're going to tell me none of the labs are wrong yet, but there's something going wrong with my child, and I need to get them somewhere safe. Parents were very much keeping their children home through that whole spidey sense period, and only when the fever broke or something, the pallor set in or the tachypnea set in that was marked, were they coming in. So anecdotally, I absolutely felt parents doing that sort of benefit burden analysis. And so the other 2 papers we have out there about palliative care and its intersection with COVID-19 is really sort of this one from the peds palliative care community. It says, hey, we're really used to talking to parents about really complex decision-making and managing and weathering all the emotions attached to that. So here's some basic tenets. Here's some principles by which the palliative care specialists always engage in conversations. And one of them is honesty and trust. And that sounds really self-evident, but we actually lead with it. And when I'm talking to a family, I actually say things like, I cannot promise to make your child better. I actually can't even promise I can get your child's pain score down to a 0. I can promise with you that I will always be honest with you, because you deserve that from me when you're up against what you're up against. And you will always, and I promise you to have my honesty if I think things are changing, right? So we just set that as a standard, which I know you guys do as well. But I think it's really important to model that, because we're also wanting to encourage families to have that kind of honesty in their home. So we have to model it. Similarly, modeling self-compassion, right? That idea of, hey, you can't be a super mom. You can't be both bubbling your kid and then worried about their wellness and struggling to know if they could just be outside with a mask on throwing snowballs, that might help your child feel a little better, right? You got to have a little self-compassion. And that starts with us modeling ourselves and maybe even disclosing at times, within reason, some of the struggles that you have felt through the pandemic as well. Then moving on to safety, this is always a theme that resides with complex medical kids. As we talked about, siblings know they have a responsibility to keep their siblings safe. And now we're adding this extra layer of masks and, oh my gosh, stay away and don't touch your face. And so trying to, with the right age population, to say, this is an area of empowerment. This is not an extra burden, right? Similarly, when we talk about sensitivity, it's meaning having a sensitivity for self, but also other, right? That really hard struggle of every family defining safety differently. And what maybe one family is doing might not be what we do, but we're going to be very sensitive to the fact that that's happening. Similarly, and this is a very key palliative care skill, which is we often tell parents who are terrified that their kid's going to ask the question, Mom, do I have cancer? Mom, am I dying from my cancer? Is to model to families one of our favorite phrases, which is tell me more. And if you remember nothing else from my talk, that is one of my favorite phrases for a couple of reasons. One, it's a beautiful stall technique while you're trying to figure out what you're going to say next. Two, it's a very open-ended empathic statement. Three, what it actually allows you to do is gather more information and make sure that your lens is as open and clear as possible and not being clouded, say, by a past perception or a personal stressor, moral distress, etc. And when we ask families to do similarly, I encourage them to do that because, a child may say, Mom, how am I doing? And if a mom doesn't check in why the child's actually asking it, or Mom, could I get COVID? Or could, Susie, my sibling with complex medical needs, get COVID? A parent's lens may go to the worst case scenario. Oh my gosh, Pandora's box has been open. And now I'm going to have this mortality talk with my child. Check in with them. Oh, tell me more. What do you mean by that? Why do you ask the question today? And you'd be amazed, right? As we all know from maybe our own office or our personal experiences, sometimes the child actually is asking the question for a very different reason. So the tell me more thing is a vector check, if you will, if you're on to the right question and answering it the way the child needs it answered. Connectivity and preparedness are both these ideas of hoping for the best, preparing for the worst, so allowing hope to have a presence. And connectedness is how are we going to connect, how are we going to have community when, even pre-COVID, I couldn't leave the home as spontaneously as someone else could have, right? And then in the time of COVID, how we're going to do that. And similar with community building, as you could imagine, it's that idea of we're all in this together, and that includes children with special healthcare needs, right? What do they add to the community? It's not us versus them. And then the large thing about palliative medicine is trying to normalize the idea that death is part of the life cycle, which is easier said than done, right? But what we always like to tell families is you are not born in this world being scared of death or hearing the word dead. That is a societal overlay on these words. And when we actually allow for families to have open conversations, it can actually blossom into some very beautiful ways about living and hope in those important constructs. So we always encourage it amongst our families. And since the news is just inundating us with all sorts of risks of death, the children are hearing it and they're absorbing it, whether we're having conversations at the dinner table or not. And so allowing, encouraging families to permit even that the word be uttered or the discussion, because you heard a news broadcast, really can allow for us to destigmatize the death anxiety that we have as a society and potentially in the home. And then finally is the idea of legacy, which is a huge part of palliative. We do not know what tomorrow brings, but this is how we honor Susie and her complex medical needs. And we're thrilled that she has been with us today, and we are hopeful she will be tomorrow. And let us talk about the ways that Susie's enriched our lives. And that's pre-COVID, and it can be in the time of COVID, right? Here's how our family has dealt with distress in the past. We have generations, we have years of how our family has done this. And we are armed to be able to go into this crisis now and endure this crisis now, because look what Susie's taught us over time. And then finally, this comes from the adult world of palliative medicine, because as you can imagine, they've had to really help a lot of colleagues work with families and patients specifically over the risk of COVID-19 and death. And so they came up with this acronym of CALMER. And what they're saying is if you as a pediatrician or you as a physician need to have a conversation with a patient or a proxy, i.e. the parents, here's a map for how to maybe think about having this conversation. So check in. How are you doing? Right? This has been a very stressful time. I've been wondering a lot about you because Susie's really medically fragile, and it really, I just wanted to check in if that's been having extra distress for you, knowing that she often can be in the emergency department or the ICU in a given winter anyway. How's it going with COVID and your worries and thoughts about that, right? And be very specific and ask about their fears, because remember that one study showed that a lot of parents are thinking about it already. And then if you can explore the conversation, right, try to lay out the issues, be very, task based about that. Have you thought about what you would do if Susie gets sick? Would you want to bring her into the hospital? Do you need more information from me about that? Have you thought about how that would impact the other kids? How are the other kids doing? Can I help you sort of think through some of those stressors? Okay. And then getting them to really motivate and talk about what matters. And by that, I mean, you've gone through some of the issues, but now let's get to the value base. What does this parent define as a good day, right? What would get them to come to the hospital? What would they seek from a value base to go into the hospital? And what would they be willing to risk in order to get that, if that makes sense? Yeah, I'd be willing to risk COVID-19 because Susie needs to live no matter what. And every winter she gets intubated anyway. The math makes perfect sense to me, doc, versus actually, I think the risk of being in the hospital is too great. I will work with you and try to manage the UTI from home. I just cannot do it. I understand that may not be as good as IV antibiotics, but that's really, it's more important for me to know that she's with me. I can't be separated from her. And then always to expect emotion and give time for it and do a pensive pause to permit that emotion. You don't even necessarily have to say something that's going to fix the emotion, because we have to assume if they're getting to that nitty-gritty benefit burden analysis, there may be an overwhelming wave of emotions. And that's the human condition. And I will tell you, there's no magical words as a palliative care doc that's going to stop that emotion. We just honor it by being present through it and saying, I'm still here with you. This emotion doesn't scare me. And I'm just going to sit here and provide presence for you. And then if you're an adult patient, or if you elicit a family-centered advanced care plan for Susie, then, write it down. And if there's a nephrologist involved or other people, try to communicate so everyone's on the same page, so this parent doesn't have to repetitively go through this very distressing conversation, which can be very difficult for them. So in summary, I really just want to highlight that there is emerging data that COVID-19 is negatively impacting wellness, both physically and psychologically. Okay. Unfortunately, there's very little known. It's specific to children with medical complexity in COVID-19's overlay, and we need to know more. So any of you are researchers or have access to, tell them we need this, because we all know this isn't going away, both literally the quarantine and the risks, but also we have to now start shifting towards what does it mean 5 years from now and 10 years from now, what these families have been through. And we're going to need to be armed with how to engage. And in the meantime, I hope some of these communication tools have been helpful for you.